Welcome to the presentation on malaria by Dr. Ignatius Cole. I'm Dr. Ignatius Cole. Today, we're looking at the epidemiology, the life cycle of Plasmodium, comparison between different Plasmodium species, symptoms of Plasmodium falciparum malaria, and how it compares to the symptoms of other malaria, the investigations, the treatment of falciparum malaria, and the treatment of other malaria, and chemoprophylaxis. So about the epidemiology, in 2018, there were 228 million patients of malaria, with over 405,000 deaths of regions endemic for malaria. More than 70% cases are in sub-Saharan Africa. So the regions affected are South America, sub-Saharan Africa, and the South Asian regions. So there are five Plasmodium species of interest: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malaria, and Plasmodium novalis, which is predominantly a simian parasite. So this is the life cycle of Plasmodium, or the malarial parasite. So in the female Anopheline mosquito, the sporozoites are in the salivary glands. So when the Anopheline mosquito or Anopheles mosquito bites a human being, the sporozoites are deposited into the bloodstream. From the bloodstream, after half an hour, they enter the liver. In the liver, they undergo a primary exoerythrocytic cycle. And during this exoerythrocytic cycle, some hypnozoites are produced in the Plasmodium vivax and Plasmodium ovale infection. These hypnozoites serve as the reservoir of infection and can cause relapses even years after the infection has been treated. Otherwise, after the cycle occurs once or twice, then merozoites are released. The merozoites go into the blood again, and this time infects the RBC. They will go through the amoeboid stage, the signet ring stage, then they will form small trophozoites, and then form schizont, and they will form merozoites. So these merozoites are formed after the erythrocytic cycle. Some of them will transform into gametocyte, a male and female gametocyte, and this male and female gametocyte will circulate in the blood. And when the mosquito, the healthy mosquito, will bite an infected human being, the gametocytes are taken in, and the female gametocyte is fertilized by the male gamete, and the zygote will form. This is the sexual cycle. The zygote will travel to the stomach of the mosquito and form a ookinete. The ookinete will penetrate the stomach wall of the mosquito and form young oocyst, which will divide into segmenting oocyst, and which will divide into ruptured oocyst, releasing sporozoites, which will travel and invade the salivary gland. So this is the life cycle, and the symptoms occur during the erythrocytic cycle when the mosquito will burst the RBC and causes release in the toxins. So this is the same life cycle, shown a bit simplified. And that's the text. You can pause and read the text. Same things, it says the same things. So this is the electron micrograph of Plasmodium falciparum oocyst lining on an Anopheline or mosquito's stomach. This is a sporozoid. Here we compare the relationship between different species of Plasmodium, Plasmodium vivax and Plasmodium ovale, Plasmodium malaria and Plasmodium falciparum. The incubation period is the highest for Plasmodium malaria, which is 15 to 30 days. Otherwise, it is 8 to 25 days. After exoerythrocytic cycle in Plasmodium vivax and ovale, they will persist as hypnozoites. But however, in malaria and falciparum, there are pre-erythrocytic cycles only, and the asexual cycle lasts for 48 hours synchronous, whereas in Plasmodium malaria it's 72 hours synchronous, and in Plasmodium falciparum it is less than 48 hours and it is asynchronous, which means that the fever periodicity is alternate days for Plasmodium vivax and Plasmodium ovale, where it is every third day for Plasmodium malaria, and there is no periodicity in the fever for Plasmodium falciparum. The fever periodicity depends on the asexual cycle, which is are regular and synchronous in these two species, occurring at 48 hours and 72 hours respectively, and is asynchronous and is less than 48 hours in Plasmodium falciparum. Delayed onset is common for oval, where it's rare for Malaria and is rare for Plasmodium falciparum too. And relapses are common up to 2 years for Plasmodium vivax and Plasmodium ovale because of these hypnozoites. And recrudescence can occur many years later for Plasmodium malaria, and recrudescence can occur up to 1 year for Plasmodium falciparum. Now going to the protective factors, the Plasmodium falciparum has influenced human evolution with the appearance of protective mutations such as sickle cell disease, thalassemia, G6PD deficiency, and HLA-B53. These genes, these disorders, these diseases will prevent against Plasmodium and malaria. And Plasmodium vivax cannot enter red cells that lack the Duffy blood group, therefore many West Africans and African Americans are protected. So about the Plasmodium falciparum infection, this is the most dangerous of all. The onset is often insidious with malaise, headache and vomiting. There is cough and mild diarrhea. Every system can be affected. The fever has no particular pattern. There is hepatomegaly and splenomegaly which may become tender. Tender splenomegaly may be present. Cerebral malaria is a dreaded complication manifested by delirium, seizure or coma. Coma occurs without any localizing signs. In case of pregnancy, there can be abortion and intrauterine growth retardation. Previous splenectomy will increase the risk of severe malaria. About Plasmodium vivax infection, the illness starts with several days of continued fever before the development of classical bouts of fever on the alternate days. So initially the fever is continuous type, and then there will be classical bouts of fever on alternate days. Fever starts with a rigor. There is a rigor phase first, followed by the cold phase, where the patients feel cold, and then the temperature will rise to about 40 degrees Celsius. And after half an hour to 1 hour, the hot or flush phase begins. In this phase, there is profuse perspiration and gradual fall in temperature. It lasts for several hours. So this cycle of shivering and feeling cold and hotness is repeated 48 hours later. Gradually, the spleen and liver enlarge and may become tender. Anemia will develop slowly. Relapse may occur 2 years after leaving the endemic area. And this Plasmodium vivax infection may be acquired by blood transfusion. So this is a picture showing the features of Plasmodium falciparum infection. You can see it can affect many systems. Neurologically, it can cause coma, hypoglycemia, seizures, cranial nerve palsies, and opisthotonus. This picture shows disconjugate gaze due to cranial nerve palsy. It can cause malaria retinopathy with Roth spots. It can cause pulmonary edema and secondary bacterial pneumonia. It can cause shock, cardiac failure, also called as algid malaria, and dysrhythmias with quinine, the cardiovascular features. In the renal system, it can cause acute kidney injury. It can cause severe hemolysis resulting in hemoglobinuria, also called as black water fever. In abdomen, it can cause jaundice. It can cause tender liver ache with hepatitis. It can cause pain in the left upper quadrant with splenomegaly. So it can cause jaundice, hepatomegaly, and splenomegaly. In the blood, it can manifest as parasitemia, anemia, thrombocytopenia, and coagulopathy. This is the blood film showing parasitemia. This is the ring form in the RBC. And these three pictures are of Plasmodium vivax infection. The ring form in the RBC, the trophozoite stage, and the season stage. So what are the investigations we can do for malaria? Well, the most important one is blood smears. Examination of GM-SAR stained thick smear is the gold standard. So this is example. This is the thick smear and this is the thin smear. They are time consuming and need expertise, but they are cheap and readily available. The difference between thick and thin blood films or blood smear is that in thick film there is lysed RBCs. In thin film there is intact RBC. In thick film we need larger volume of blood. In thin film we need a smaller volume of blood. And in thick film there is 0.25 microliter blood per 100 fils. In thin film there is 0.005 microliter blood per 100 fils. And in thick film, we have more difficulty in diagnosing a species. It is primarily used to calculate the parasite density. And in thin film, we use it for species differentiation. But in cases of low density of infection, the infection may be missed in thin film. Other investigations include the immunochromatographic rapid diagnostic test, or the RDTs, which include the optimal test, which detects the Plasmodium LDS. This is the optimal test, which will detect negative, or it can detect Plasmodium vivax and Plasmodium falciparum. It can differentiate between the two of them. The parasite F test, which will detect the Plasmodium falciparum histidine-rich protein 2, or PFHRP2. The QVC malaria test, and the DNA PCR. About the treatment of malaria, the falciparum malaria. Since Plasmodium falciparum is now resistant to chloroquine and sulfadoxine pyrimethamine, also called Fancida, almost worldwide, artemisinin-based treatment is now recommended. For mild cases of falciparum malaria, we prefer co-artemether, which contains artemether and the lumefantrine. So we give 4 tablets orally at 0, 8, 24, 36, 48, and 60 hours. We give 6 doses at 0, and other are usually multiple of 12, 0, 8, and multiple of 12, 24, 36, 48, and 60 hours. We give co-artemether. This is the preferred therapy. If the Plasmodium falciparum in that area is still sensitive to quinine, we can give quinine, 600 mg of quinine salts 3 times a day, orally for 5 to 7 days, together with or followed by doxycycline, 200 mg once daily for 7 days. So we can give quinine plus doxycycline therapy, quinine plus clindamycin therapy for pregnant women or young child. Or the alternative is atobacone proguanil or Malarone tablet, 4 tablets orally once daily for 3 days. If the patient is pregnant, we can use co-artemether or quinine plus clindamycin. So other regimens are also present, like the artesunate and mefloquine regimen. So what determines severe falciparum malaria? These are the features of severe falciparum malaria: coma, impaired consciousness, prostration, very severe weakness such that the patient is unable to walk or sit up without assistance, the failure to feed, multiple convulsion, acidotic breathing, severe circulatory collapse or shock, clinical jaundice, hemoglobinuria, abnormal spontaneous bleeding, pulmonary edema. Parameters to detect severe malaria are hypoglycemia, metabolic acidosis, severe anemia, hemoglobinuria, hyperparasitemia, hyperlaxatemia, and renal impairment. So once we find out that the falciparum malaria has become very severe, we will give the therapy for severe falciparum malaria, which is the preferred therapy is, again, it is artesunate. Artesunate 2.4 mg per kg IV dose at 0, 12, and 24 hours, and then once daily for 7 days. So once the patient is able to take orally, then we will switch to 2 mg per kg oral dose, and the total dose is 17 to 18 mg per kg. So we give total 17 to 18 mg per kg artesunate. The alternative therapy is quinine. So the quinine, if the malaria Plasmodium falciparum is susceptible to quinine, we can give quinine loading dose of 20 mg per kg IV over 4 hours up to a maximum of 1.4 gram, and then maintenance doses of 10 mg per kg quinine salt given as 4 hours infusions 3 times daily for the first 48 hours, then twice a day up to a maximum of 700 mg per dose until the patient can take drugs orally. So we will load the patient with a 20 mg per kg IV dose for 4 hours up to 1.4 gram. Then we'll give maintenance dose of 10 mg per kg of 4 hourly, 3 times daily. So we give 10 mg per kg 3 times daily for the first 48 hours. And then we'll give maximum 700 mg per dose. And then we can continue that with the oral therapy as mentioned earlier and combined with doxycycline or clindamycin. So note that the loading dose would not be given if quinine or mefloquine has been administered in the previous 24 hours, and the patients should be monitored by ECG while receiving quinine because it can cause arrhythmias. So complications of severe falciparum malaria can include coma, hyperpyrexia, convulsions, hypoglycemia, severe anemia, acute pulmonary edema, acute kidney injury, spontaneous bleeding and coagulopathy, metabolic acidosis, shock or algid malaria, aspiration pneumonia, and hyperparasitemia. So how do we manage non-falciparum malaria? So the preferred therapy is chloroquine. 600 mg of chloroquine base orally, followed by 300 mg base in 6 hours, and then 150 mg base twice daily for 2 days. So once single dose of 600 mg chloroquine, then a single dose of 300 mg chloroquine, then 150 mg chloroquine twice daily for 2 days, plus primaquine. So the primaquine is given 30 mg or oral daily, or 15 mg oral daily for Plasmodium oval for 14 days. So primaquine is given for 14 days after confirming G6PD negative. But if the patient has mild to moderate G6PD deficiency, then we can give chloroquine plus primaquine 0.75 mg per kg weekly orally for 8 weeks. So if there is G6PD deficiency, then this is the recommended therapy. And for chloroquine resistant Plasmodium vivax, we can give coartemita is recommended for Plasmodium falciparum. So this is for non-falciparum malaria. Chloroquine is still the mainstay of treatment. So talking about chemoprophylaxis of malaria, the drugs used depend on whether the chloroquine resistance in the region is high or absent. So if the resistance is high, you can use mefloquine, doxycycline, or Malaron. Or if the chloroquine resistance is absent, we can use chloroquine plus proguanil. The dosage and the regimen is given here. You can pause and see it. Please subscribe to this channel. Thank you for watching the video.